Alterations in elimination, renal, disorders of the bladder and urethra. Urinary retention is the inability to urinate or effectively empty the bladder. This can be acute or chronic, and we may see that residual urine. Acute retention is seen in complete urethral obstruction after general anesthesia, excuse me, or with certain medications, and these clients may be unable to void at all. Chronic retention is seen with prostatic enlargement or neurological disorders, and these clients can void, but they're unable to completely empty the bladder and they have a large residual volume. This is more common in men, especially after the age of 70. So these clients will have a sudden inability to void. That bladder can be distended. They may begin to experience severe lower abdominal pain in acute retention. And with chronic retention, they may have difficulty in starting the stream of urine, and they continue to feel the urge to void despite having just voided. They may develop bladder infection or dribbling of urine. So when that urine just remains in the bladder, it's called stasis. And as it sits there, it is more likely to develop bacteria. So we can look at a urinalysis, we can do a catheterization or ultrasound to determine if there is any residual urine. So with acute retention, we're going to do immediate catheterization. This is usually just going to be a straight cath. With chronic retention, there may be a permanent drainage system, such as a suprapubic cath. We may encourage the clients to use the Credé maneuver, where they actually take their hands and they push on the bladder as they're trying to void to help push the urine out, or doing the Valsalva maneuver to help internally push the urine out. We may do intermittent catheterization, and for some men, we may have to do surgery. It is very important that we monitor I&O and palpate the bladder for distension and monitor for symptoms of UTI. True or false? The customary solution for urinary retention is developing a permanent drainage system. This is true. Urinary incontinence is the involuntary passage of urine temporarily or permanently. It does occur in at least 1/3 of older adults in the community and 1/2 of older adults that live in institutions. It's considered not only a physical problem, but also a psychosocial problem. If you are constantly leaking urine, you don't really want to be around other people because you begin to have an odor. You may have wet clothing, etc. This can be caused by bladder or urethral dysfunction, a failure of the urethral sphincters to hold urine, an overactive bladder. This can cause frequency and can lead to incontinence. There are numerous risk factors for incontinence listed in your textbook, and I will let you review those in your textbook. There are also several drinks or medications that may increase the risk for temporary urinary incontinence, such as alcohol, caffeine. Remember, these are going to have kind of a diuretic effect. But decaffeinated tea and coffee can also increase the risk for urinary incontinence, as can carbonated drinks, artificial sweeteners, corn syrup, foods that are high in spice, sugar, or acid, Some of your heart and blood pressure medications, sedatives, muscle relaxants, and large doses of vitamins B or C. So there's several different types of incontinence. Stress continence is probably one of the more common ones. This is going to be leakage of urine during conditions that will increase intra-abdominal pressure, such as exercise or lifting heavy objects, laughing, coughing, or sneezing. Urge incontinence is actually caused by involuntary contractions of the detrusor muscle of the bladder. So this leakage of urine occurs shortly after feeling that urge to void. Basically, when you feel like you need to go, if you don't go right now, you will have incontinence. Reflex urinary incontinence is an involuntary loss of urine at a fairly predictable interval after a certain volume in the bladder is reached. Overflow incontinence is where we have a leakage of small amounts of urine if the bladder is too full. Functional incontinence is usually seen in older adults that have normal urethral and bladder function. It changes changes in the functional ability might be due to cognitive or physical abilities. So basically, we have a leakage of urine because the client is maybe unable to get to the bathroom fast enough because they have, let's say, maybe arthritis, or have a knee or a hip that just does not function appropriately. Or maybe they have some issues with their hands and they're unable to unfasten their pants fast enough. So basically, they just have changes in functional ability. So clients with incontinence may have urgency or frequency. They may leak small amounts of urine when they're coughing or sneezing, or just have a complete inability to control urine. If it's a cognitive issue, then they just may not recognize that they need to void. We can diagnose this with urine culture and sensitivity, cystoscopy, cystogram, a urodynamic study. Remember, that would basically be looking at the flow of urine, or a pelvic ultrasound. We are going to try and correct this disorder. There are some pharmacological agents that may be available, in other words, some medications. And there's also some surgeries that might be available. One of the medications we might use would be an anticholinergic for that overactive bladder. This could basically increase the client's heart rate and cause urinary retention because an anticholinergic is going to kind of dry us up. So now we also have decreased sweating and decreased bronchial secretions, decreased saliva and gastric secretions, and this can also increase intraocular pressure. One of the main drugs in this category would be oxybutynin. So very important when we have a client with incontinence to help prevent skin breakdown. We need to reduce anxiety. We may initiate bladder training to help take care of this issue. Teach the client how to do Kegel exercises. And this is not only for women, but also for men. They may need to wear barrier garments or external collection devices. One thing we might do is what we call a post-void residual volume. This can either be done by ultrasound to determine the amount of urine remaining in the bladder following urination, or it can involve insertion of a catheter into the bladder immediately following urination to see how much urine we're able to drain. 50 mLs of urine or less should be what we discover, but In the older adult, because of aging changes, we would accept up to 100 mLs. Bladder retraining will use client education, scheduled toileting, and positive reinforcement. These clients are basically going to be scheduled to urinate every 2 to 3 hours while awake, with the length of time between voidings being gradually increased. We can do pelvic muscle rehab to strengthen the pelvic floor. That includes pelvic floor exercises with or without biofeedback. We can do pelvic floor electrostimulation, or in women, vaginal weight training, where we insert these small weights in the vagina and they have to hold it in place. And we can also do urge suppression. However, it can take 6 to 8 weeks to see significant results with this rehabilitation. The external urine collection devices are useful for men. These are latex sheaths. They're also known as a condom catheter or a Texas catheter. It's basically slipped around the penis with a tube attached to a drainage bag, and then there is a appropriate device to secure it in place. We should never use tape to encircle the penis. Indwelling catheters, excuse me, are not an appropriate option if we're just looking for convenience because of the high risk of infection. Clients may do intermittent self-catheterization where they're taught a clean, not sterile technique to catheterize themselves to drain urine. A pessary would be a device that's inserted vaginally, and that will help hold pelvic organs in place, but it can also be used to treat incontinence in women. It is important, if a pessary is placed, that within 24 hours the client is re-examined to ensure proper placement and rule out urinary obstruction. The device does have to be removed periodically to be cleaned and replaced. We can also implant electrodes that stimulate pelvic floor muscles to contract to help prevent urinary incontinence. Cystitis is inflammation of the urinary bladder, usually from bacterial infections. It can be caused from invasive procedures such as a cystoscopy or insertion of a urinary catheter. Fecal contamination, prostatitis, BPH, indwelling catheters, pregnancy, and sexual intercourse. It is more common in women because of the short urethra and proximity to the rectum. These clients are going to have pain or urgency, frequency, low back pain, dysuria, cloudy and or strong smelling urine. They may have hematuria, nocturia, spasms of the bladder, low-grade fever, and fatigue. We diagnose through microscopic examination. We can do a culture and sensitivity. We may also do an IVP or a cystoscopy for repeated episodes. We're going to manage it with antimicrobial therapy and the administration of cranberry juice. Some people will take cranberry capsules. So some of these antimicrobials that we'll use for this particular situation would be sulfonamides. This is a broad spectrum antibacterial that we frequently use with UTI, especially when we combine it with trimethoprim. We can also use it for respiratory tract infections or opportunistic infections and pneumonia. Be aware that this should not be administered to pregnant women or infants younger than 2 months. This particular antibiotic does have a high risk of drug allergies. So a lot of the adverse effects we see are going to be those allergic reactions. These clients may also develop that photosensitivity. So if they go out in the sun, they can burn much more easily. Then we have a few other complications. We do need to know that our oral anti-diabetic medications are some of them are what we call sulfonylureas, and they're very similar in composition. So if we are administering a sulfonamide, it can increase the effect of the sulfonylurea, increasing the risk of hypoglycemia. We also need to be aware that these clients can develop crystals in the urine, which can potentially cause blockage. So it's really important that we encourage fluids. So the trimethoprim, basically, as I said, is going to be combined with the sulfonamide, and we frequently give it once again with the UTI or pneumonia. Again, encourage fluids, and we also encourage the client to take this on an empty stomach. The next one is going to be our penicillins, such as amoxicillin. We know that this is an antibiotic. Again, being aware that a lot of our adverse effects are going to be related to potential um, allergic effects. Tetracycline, we have talked about this. Again, being aware that with this medication, we should not give it to pregnant women, women who are breastfeeding, or children under the age of 8 due to its discoloration of permanent teeth, tooth enamel hypoplasia, and retardation of the fetal skeletal development. It also does have photosensitivity as an adverse effect. This would be our doxycycline. Another medication we might give would be antiprotozoals. So we give this for protozoal infections or bacterial infections. Again, being aware that a lot of our drug allergy symptoms might be listed here, but this also has the adverse effect of neutropenia and nephrotoxicity. Metronidazole is going to be the main medication here. Other medications include our urinary tract antiseptics that we give for UTIs. They can cause some discomfort in the abdomen. We may also see neuropathies or hepatotoxicity. We may see changes in the cardiac function. So again, with cystitis, very important to encourage fluids and to teach preventive methods, such as making sure that we do appropriate perineal care. Women wipe front to back only, etc. We need to encourage adequate fluid intake. Cotton underwear, which will allow the perineum to breathe. When we use the nylon or synthetic materials, it can actually hold moisture close to the perineum, and this increases the risk of infection. Encourage showers versus baths. Encourage urination before and after intercourse. And of course, women cleansing appropriately and making sure underwear is not too tight. Foods and fluids that can cause irritation to the urinary tract system include the coffee, tea, carbonated beverages, even without caffeine, alcohol, and citrus, such as oranges, grapefruit, lemons, and limes. Spicy foods and tomato-based foods or fluids, and chocolate. True or false? To treat cystitis, ingestion of cranberry juice or vitamins are recommended. And this is true. Urethritis is going to be inflammation of the urethra caused by microorganisms. This is more common in men than women, and it may accompany cystitis or vaginal infections in women. These clients will have dysuria, urinary frequency, urethral discharge, urgency, bladder spasms, and again, cystitis may also be present. We can do a urethral smear in men and a urinalysis in women. We treat it with antibiotics, liberal fluid intake, analgesics, and warm sitz baths. Make sure that we instruct our clients to complete a full antibiotic regimen. If they stop taking it too soon, we can start causing the mutation of the bacteria and cause resistance of the antibiotic. Frequent perineal care should also be done. Be aware that we need to instruct our clients that the use of scented soaps, bubble baths, or perineal deodorant sprays can increase irritation. Bladder stones. The formation of stones in the bladder or the upper urinary tract that migrate to the bladder are what we call bladder stones. This can be caused by urinary retention, urinary stasis, enlarged prostate, and immobility. Most calculi are precipitations of calcium salts. So let's say we have an issue with the parathyroid where we have high levels of calcium in the blood, we're going to be at higher risk. Or if we're dehydrated, we're at higher risk for development of these stones. Can also be formed by uric acid, magnesium, ammonium phosphate, or cysteine. These clients will have hematuria, cloudy or dark urine. They may have suprapubic pain, difficulty starting the stream of urine, pain with urination, pain in the flank, abdomen, or groin as the ureter spasms as it tries to move that stone through the ureter. There may be nausea, vomiting with this pain, along with symptoms of a UTI. We diagnose it with a cystoscopy, a KUB study, IVP, ultrasound, and/or a 24-hour urine collection. We can treat it with lithotripsy, where we actually break up the stone, surgical incision, a low purine diet, and increased fluid intake. Very important that we do I's and O's, that we as nurses encourage our clients to take fluids, and we educate the client on how to strain their urine. If they have stones, then we want to send the stones to the lab for diagnosis as to what it is composed of, if at all possible. Malignancies of the bladder. The bladder cancer is the most common urinary system cancer. It does occur in men more often than women. And the use of tobacco products, carcinogen exposure, chemical and fume exposure, and recurrent UTIs can actually be the cause. These clients have painless hematuria. They have a change in the color of the urine. They may have UTI symptoms, anorexia, and weight loss. We diagnose with microscopic biopsy, cystoscopic examination, retrograde pyelogram, CT, radiographs, and ultrasound. We may treat it with anti-neoplastic drugs, photodynamic uh, procedures, radiation therapy, cystectomy, and bladder resection. A urinary diversion procedure and urostomy may be required. An ileal conduit, a continent urinary diversion, ureterosigmoidostomy, where the urine drains continually into the rectum. Very important that we as nurses provide appropriate pre- and postoperative care, emotional support, and again, they may require enemas preoperatively. So a client is suspected to have bladder stones. How many hours should a urine sample be collected for as part of the diagnostic workup? 24-hour urine collection. Trauma to the bladder can occur from a gunshot or a stab wound or crushing injuries or forceful blows. It can result in tears, hemorrhage, or penetration that causes urine to leak into the peritoneum. Damage to the kidney can result in bruising or tearing. These clients may experience anuria. Remember, if we have an A, that means absence of. Hematuria, pain in the abdomen, and symptoms of shock. We diagnose with abdominal x-rays, cystoscopy, IVP, and/or exploratory surgery. Surgically, we would repair the wound. It may require a nephrectomy, a cystotomy, a cystectomy, or placement of an indwelling urinary catheter. As nurses, we need to recognize any abnormal findings. If blood is noted during the insertion of an indwelling urinary catheter, we should immediately notify the healthcare provider. And now your post-test.